Alright, Assalamu alaikum everyone. Ramadan Mubarak. My name is Alkatmah. I am a third year medical student and I'll be delivering a PAL session on the menstrual cycle today. I know some of you guys may see the topic as a hard one or challenging one. Inshallah, it won't be after this PAL session. And yeah, feel free to ask any questions. And even afterwards, if you feel like you have any questions, you can message me or email me at any time. I do not mind at all. And yeah, without further ado, let's start first with the dua. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما. يلا بسم الله. The objectives are the exact same ones as found in the lecture. I won't be reading them, but basically how the session will go, I'm going to talk about some like the overview of the menstrual cycle, and then I'll be going through the phases. So the whole cycle, each phase, and so on. Then I'll be going through some clinical correlation, and lastly, I'll be having some questions so that we can review the topics together, inshallah. All right. So first of all, what is the menstrual cycle? It's a cycle that begins at a puberty, when a female hits puberty, and its sole function is to prepare the body for a pregnancy. If not a pregnancy, menses or like menstruation or bleed or period or bleeding, it has so many names, right? So usually it lasts around 28 days. However, it can be shorter, it can be longer. Generally differs from a person to another. And yeah, as we said, its sole reason is to make reproduction possible. It usually consists of the two main organs here that are the ovaries and the uterus. However, it's very important to know that the menstrual cycle consists of two synchronized cycles. So when we're talking about menstrual cycle, we're talking about the ovarian cycle and the uterine cycle. Both are dependent on each other, both go together, and yeah, the ovarian cycle is the development of the follicle and then the ovulation of this follicle or egg, and it repeats. The uterine cycle is the functional endometrium thickening, and then the shedding of this thickening in case there was no pregnancy or there's no pregnancy. Here's like a small picture of the endometrium, as you can see. As you can see here, but we're going to go through it in more details later on. But the endometrium is basically just the inner layer, most inner layer in the uterus, and it's the one we're going to be focusing on when it comes to the menstrual cycle. There are layers to it, and the one we'll be focusing on even more is the functional one today, inshallah. Okay, let me just okay. So as I said, starts right at puberty. The first period is called a menarche in medical terms, and it, as I said, usually consists of 28 days. When a period stops, it's called menopause. And first 5 days of the cycle are what we know as the menstruation, the bleeding, or the menses. Usually the 14th day is the ovulation. And if we want to divide the cycle in like ovarian cycle terms, we can divide it into two. First half being from day 1 to day 14. We can call it the follicular phase. It's usually the pre-ovulatory phase, so before the ovulation. And here we're mainly talking about the menstruation and the proliferation of the endometrium. The second half is going to be the post-ovulatory luteal phase, so after ovulation, and we're talking about the secretory phase, which is basically where the endometrium starts like having those glands in the endometrium that will secrete substances and so on. Okay, before we start with the diagram, I have to say one more thing. Very major, very important. We need to know that the whole cycle is regulated by the mastermind, which is the hypothalamus. The masterminds, which are the hypothalamus and the anterior pituitary. they release hormones that regulate the whole cycle. What happens is that the hypothalamus releases the gonadotropin releasing hormone. All right? It moves down to the anterior pituitary and releases the FSH, follicle stimulating hormone, or the LH, luteinizing hormone. Now, how does the GnRH know what hormone to release, since it releases both? Subhanallah, it's based on pulses. So if there is a high frequency of the pulses of GnRH, which is about 1 every 60 to 90 minutes, it will stimulate LH. And if it's a low frequency, so like about 1 every 120 minutes, it will stimulate FSH. All right? Now, I think you have already covered this in another lecture. I'm not going to go through details, but because we're going to be mentioning this a lot, I thought we can do a quick revision of the follicle. Follicle is basically a primary oocyte surrounded by granulosa cells and wrapped by theca cells. All right, this all makes a follicle, which sits in an ovary, which again is our main focus or like topic for today. All right, now if all is good and all is set, we can start with the menstrual cycle. The diagram here. I'm pretty sure you guys have all saw this diagram before. And I can understand that it can be intimidating at first, but inshallah, I believe once you grasp it and understand it, it will be very easy, inshallah. And it will be very helpful, and you'll be able to answer any question that comes your way, inshallah. So let's start with orienting ourselves, okay? As we can see here, I told you this before. The menstrual cycle is 2 cycles, right? The ovarian cycle here and the uterine cycle, which is the one illustrated here. It's the endometrium and so on. We can see here the menstruation, the proliferative phase, the ovulation, the secretory phase, all right? And the ovarian cycle is right here. So we have the follicular phase and the luteal phase. Okay. How does this all start? We said that it starts with the GnRH, the gonadotropin releasing hormone, releasing FSH and LH. Okay, we can see that now we'll be talking about the ovarian cycle first, okay? I'm going to focus on it first in regards to the hormone levels, okay? That's what happens when a hormone increases and decreases and its corresponding event in the ovarian cycle, and then I'll be talking about the uterine cycle. So we can see that in the beginning, all hormones are low, all right? There is no increased hormone, and in the ovarian cycle, we have this oocyte here, all right? When FSH and LH are being released from the pituitary gland, they go to the ovaries, and they stimulate the ovaries to like pick or choose a follicle that will, like a bunch of follicles that will grow, okay? That is usually the role of FSH, okay? So FSH will be the main focus here. And we are talking here about the follicular phase, right? So from follicular, remember, FSH is the main hormone that is working here. When FSH recruits those eggs, the estrogen, the egg growing will release estrogen, okay? And we can see here that estrogen starts increasing, okay? As estrogen increases, it sends a signal to the pituitary gland to stop releasing FSH and release more LH. So we can see that I'll change the color so it's better. We can see here that the FSH goes up and then comes down, okay? Because خلاص we inhibited it from the pituitary gland. But the LH starts going up, okay? Why is that? It's because the LH will help in the growth of the egg or the follicle, okay? So as we can see here, the egg is growing day by day, as you can see down, and it keeps on increasing until, and with its growth and increase, more estrogen is being released, of course. So something very interesting happens here is that I did say that the estrogen increasing inhibits the FSH, right? But that is when the estrogen is in low amounts. If it's in high amounts, subhanallah, it does the opposite. It stimulates the LH and FSH to release more. So as the egg is increasing, as we said, it's increasing in size and it's growing, the estrogen is increasing too. When the estrogen increases highly, the FSH and the LH increase too. What happens when FSH and LH increase is that this egg that got recruited, which is the best egg with the best growth and so on, it will burst and it will release the egg inside it. The follicle will release the egg. Okay, how does that happen? It's brought about by the increased amount of LH and FSH. Okay, when LH and FSH, when does that happen? It's in the ovulation day. So basically around 14th, like 13th, 14th day, around that. When that happens, it marks the end of the follicular phase. So خلاص, here we are done with the follicular phase. The egg got released, ovulation is done. That's it. When we start the luteal phase, what happens? Basically, first of all, the estrogen, like all three hormones, the estrogen, the LH, and the FSH start decreasing. Why? Because خلاص, the egg got released. There's nothing they can do right now. So they all start dropping down. Other than that, this body that the follicle that released the egg starts degenerating. What do we call the body that like starts degenerating from the follicle? It's called the corpus luteum, I believe. Corpus luteum basically means translation of it is yellow body. Okay, corpus means body, luteum means yellow, and it's exactly what we can see here. Why is it yellow? It's because it's made of cholesterol. All right, and if we know, well, we all know, I'm pretty sure, is that cholesterol brings about what was it? It was progesterone, right? Yeah, progesterone. And progesterone brings about androgen. Lastly, androgens can release estrogen. Okay, with that in mind, we can like understand this better. As we can see, the corpus luteum is what we have here, right? And what hormone is increasing? It's the progesterone. So the progesterone starts increasing due to the corpus luteum. It is what is releasing this hormone. Okay, so as the progesterone gets increased, it as I said here, some of it becomes estrogen. So we can also see that estrogen also increases a bit. Not too much though, not as much as we can see over here. Okay, so in the luteal phase, what's increasing is mainly the progesterone and a little bit of the estrogen. However, the LH and FSH are inhibited. It's because progesterone inhibits LH and FSH. Why is that? Okay, before I tell you, I'm going to talk about the uterine cycle because it will make more sense, okay? But we can see here in the uterine cycle that the first day, as I told you guys, is the menstruation, okay? Menstruation, we start, of course, with the bleeding. What the drawing here illustrates is the endometrium, okay? So the innermost layer of the uterus. We can see here that it starts thick, okay? And then all this bleeding happening will decrease from the layer of the endometrium. It keeps on decreasing and decreasing until it becomes thinner, right? And we can also see here that the hormones are low, right? When it's bleeding, when there's menses. However, when it starts, like when bleeding is done at around the 6th day, and we start the proliferative phase, which is around the 7th day, we can see that the hormones are starting to increase. What hormones? Mainly the estrogen. The estrogen is responsible for the proliferative phase. Okay, so as we can see here, there is a thickening of the endometrium layer starting to happen, and the more estrogen that is coming, the more the layer that gets thickened. Then we said ovulation phase, but then what I want to focus here on is the secretory phase. Secretory phase, the layer becomes most thickened. Why is that? It falls under or also within the luteal phase from day 16 to day 28. So the question that I was telling you guys about, it's like, why is the progesterone high and the endometrium layer thickened at the same time? It's because we just released an egg, right? This egg might have the possibility to be fertilized in the fallopian tube or somewhere in the uterus, right? Mostly in the fallopian tube, after the fimbriae have collected this egg, I mean. So if the egg is collected, it might be fertilized and then it might get implanted into the endometrium, which might, like, we're talking in case pregnancy happens, right? So if we want this egg to be implanted, we want the endometrium to be as thickened as possible for it to like stay safe there and like stay safe and everything. Okay, so that's why the progesterone will keep increasing and keep thickening the endometrium until it knows if there is a pregnancy or not. If there is a pregnancy, as I said, the progesterone will keep increasing. Why? Because I told you progesterone inhibits the FSH and LH, and we need them inhibited because خلاص, we don't want another ovulation to happen. We already have this pregnancy, right? In case there was no pregnancy, and the how do we know أصلا if there's a pregnancy or not? If subhanallah, if this egg gets implanted in the endometrium, there is a specific hormone. I don't think you guys covered it, but it's called human chorionic gonadotropin hormone. It gets released and it informs the body that there is a baby. That's why the progesterone won't fall down. It will stay increased, right? If there is no hormone, chorionic gonadotropin hormone, the progesterone, the body will know خلاص ما في baby, there's no baby, so the progesterone will drop down. If the progesterone drops down, the endometrium starts shedding. And what is shedding? It's the bleeding and it's the menses and it's the period or the menstruation. All right. So I think that is it for this diagram. But I'm going to repeat it like quickly, just so like we are sure we have covered everything. As I said, ovarian cycle, it has the follicular phase, luteal phase. Endometrium cycle, it has menstruation, proliferative phase, ovulation, and secretory phase. We start with the ovarian cycle, where the FSH and LH are being released and the egg is growing. As the egg grows, more estrogen is being released. When estrogen is released, at first, because of the low amount of estrogen, the FSH and LH will be inhibited. As estrogen increases more and more due to the growing egg, it will stimulate the LH and the FSH. All right, so we're going to do a quick revision of the whole diagram to make sure you got it all covered. So as I said, let me bring. Okay, so as we said, it starts with the ovarian cycle, which has the follicular phase, the luteal phase. The ovarian cycle starts with FSH and LH being released. After they recruit like certain amount of eggs. I think around 20 eggs. The FSA, like one egg starts, or all of those eggs start like growing in size, which will release estrogen. Estrogen, low amounts of estrogen, in the beginning will inhibit the FSH and LH. All right. So as we can see here, more estrogen, low FSH and LH. But then when the egg is growing even more, the estrogen increases, and this will do the opposite. Because of the high amounts of estrogen, it will stimulate and both LH and FSH this time. This is what we call as the LH surge. Okay, LH surge is what brings about the ovulation, as we can see here. Ovulation is what happens in around the 14th day, is what marks the end of the follicular phase. Okay, which we said is mainly um, regulated by the FSH hormone. However, خلاص هلا we finished with the follicular phase. We're starting with the luteal phase. When the egg is released and the ovulation is done, as we said, LH, estrogen, and FSH all go down because they finished their job. The egg got ovulated. That's it. What does the body that was holding the egg turn into? We said corpus luteum. Okay. Corpus luteum is made of cholesterol, which will turn or release progesterone. Progesterone being released will increase, and when the progesterone increases, some of it may turn into estrogen, which will increase, as we can see here, but not as much as it was in the follicular phase. All right. What is decreased though is the LH and the FSH. They're decreased because the progesterone inhibits LH and FSH. Why does it do that? Because we said that during this secretory phase, or between day 16 and 28, this is the time, or this is what we call as fertilization window. It is where the egg can go to the endometrium and get implanted there. In case the egg got fertilized with sperm in the fallopian tube or so on, and it gets embedded in the endometrium, this is what we know as pregnancy. What will this release? Or it will release a hormone called human chorionic gonadotropin hormone. Okay, this hormone will signal to the body that there is a pregnancy happening on, so progesterone will keep getting it won't be inhibited. It will keep the body will keep releasing progesterone. Okay, if there is no pregnancy, the egg didn't get implanted in the endometrium at all, there will be no human chorionic gonadotropin hormone, so the progesterone will start going down. When the progesterone goes down, the endometrium will get a sign that there is no pregnancy, so menstruation can happen. As we can see here, the thickening will start decreasing, and then we'll start back from day 1, which is the bleeding, and it even loses its the thickness of it even more, so it will become very thin. We lose it all, we'll shed it all as blood. And yeah, that is it. That is mainly it. I hope you guys inshallah got it. خلص هوني in the end of the ovarian cycle, the corpus luteum gets degenerated, and will leave. It will go, and we start again with the ovarian cycle with another egg. And yeah, that is it for the diagram. Here's a checkpoint. If you guys have any questions, feel free to ask. Okay. Inshallah, I hope everything is very clear. If not, as I said, you can always text me or email me. I do not mind. Okay. here, it's just whatever I said written in words, so that you can revise it again. I'll go through it again quickly because there are more details here that I didn't mention, and these are exactly the same exact slides as Dr. Abdul Jabbar's. So yeah, um, we he did start from the wait from the absence of fertilization. So when there is no pregnancy, so he's talking about the uterine cycle here. Okay, so as this is the corpus luteum um dies, which is at the end. So here we said towards the end of the cycle, there is no progesterone, there is no estrogen, and there is no inhibin A. I didn't mention inhibin A. Inhibin A is basically just a hormone that works on the negative feedback. It's released from the ovaries, and it works on the negative feedback of um, FSH and LH. Okay, so on the other hand, here we have the pituitary gonadotroph. The event happening here is that the there will be no feedback. Okay, they are released from feedback inhibition. Why is that? It's because I said there is no inhibin A. If there is no inhibin A, there is no inhibiting. So the feedback inhibition will stop. Okay, this will make what feedback inhibition we're talking about? We're talking about the FSH inhibition. If there is no inhibition of the FSH will rise. Okay. Um, if the FSH rise, this will cause like the bleeding, as we said. We also talked about it recruiting the follicles, as I said here, 20 follicles to start the gonadotropin dependent growth. All right, those follicles growing will produce estrogen and inhibin B. Inhibin B is again the negative feedback that inhibits the FSH. Okay, I mentioned this. I said because the estrogen is increasing, but it's increasing in low amounts that will inhibit FSH. When it increases in high amounts, it will stimulate FSH and LH. Okay, I don't want you guys to mess this up. Okay, then the pituitary gonadotroph event, the pituitary responds to increasing estrogen and inhibin A by decrease of FSH, as I said, and yeah, this is by the pulses that we mentioned. Okay, the menstrual cycle, decrease in FSH will cause the death of the recruited follicles, except for the dominant follicle. Okay, yeah, this is important because we said that we recruited 20 follicles, right? All of them will grow. However, one will be the best. It will grow the best in the best conditions and so on. And of course, we want the best egg in the best conditions to be ovulated in case there was a pregnancy happening. Okay, so the dominant follicle will be the only one like alive here and continuing the cycle. So yeah, this growth of this follicle will secrete even more estrogen, or what we know here as estradiol 17B or beta, and inhibin B. Why? It's because we said we still want to inhibit the FSH release, okay? However, the FSH will induce the LH receptors because we want the growth, okay? LH will help with the growth of this dominant follicle. This keeps on going until the estrogen exceeds 200 pg per milliliter for 2 days. This is what brings about the positive feedback and increases the LH and the FSH. This is what brings about the LH surge, as we said, okay? All right. Then the menstrual cycle, which is the menstrual cycle stage 7, which is the ovulation, okay? In the ovulation, the LH surge is what, okay? The LH surge is the like main event that brings about ovulation. This is very important to know. Okay, and and what causes the LH surge? It's the increasing amount of estrogen. As we said, the more than 200 picogram per milliliter of estrogen for 2 days will cause the LH surge, which will cause the ovulation. This is very important. Okay. In the ovulation, so the primary oocyte will complete its growth. The wall of the follicle will break down, and the theca cells and the follicle and the granulosa cells will become the corpus luteum. This is what we discussed. Okay, and yeah, this is mainly it for the ovulation. For the last stage, which is the luteal stage, the increasing progesterone and the little amounts of the estrogen, not big amounts of estrogen, will inhibit both FSH and LH. Not only that, there is also inhibin A. Inhibin A is, as we said, also from its name, you can infer that it's inhibiting. What is it inhibiting? The FSH and LH. Okay, this is the negative feedback on the pituitary. The corpus luteum will die off, and the progesterone and the estrogen start to decline by day 24, which will remove the negative feedback of the FSH and LH, so the FSH will increase and the entire process will begin again. All right? Okay, here is a slide on the structure of the endometrium. This is focusing on the endometrium or the uterine cycle. And yes, basically here you have to see first that the endometrium is composed of the functional zone and the basal zone, okay? And then underneath the endometrium is the myometrium, which is the muscle, the smooth muscle. The functional zone is our main focus for the whole menstrual cycle. It's the zone being either in the proliferative stage being thickened, or in the secret or later on in the menstruation being shedded. Okay. They mention here that it's composed of simple cuboidal columnar epithelium. I think it's just good to know, and it's supplied by spiral arteries, okay, which are branches of the uterine arteries. We can see them here. All right. They then branch off to form the subepithelial plexus, which form venous lakes or lacuna. The lamina propria is densely cellular, which is what we see here. And the functional zone is shed during the menstruation. Again, this is everything we have said. It's just repetition. And yeah, the basal zone is supplied by straight arteries. I think this is also good to know. And yes, it reforms after the menstruation. Here it's again the uterine cycle, but in more details. So, first of all, it's controlled by the ovarian estrogen and progesterone. We said they're both dependent on each other. They both start together and go together and everything. Okay. We said what were the two phases of the ovarian cycle? They were the follicular phase and the luteal phase. Okay, follicular by FSH, luteal by LH. For the uterine cycle, it's two phases. The proliferative phase, day 5 to 13. So after menstruation is done up until just before the ovulation. Okay, and the second phase is the secretory phase, which is after the ovulation until the end of the cycle, day 26. Okay. So in the proliferative phase, it says here that after the menses, when the functional layer is shed, the basal layer will start thickening again. Okay, and that is due to the increasing amount of estrogen, right? It induces the cells of the basal layer to proliferate. We mentioned this. estrogen will also induce the expression of progesterone receptors so that the endometrium will respond to progesterone in the luteal phase. Okay, I didn't mention this. This is also important. Okay, we said that the thickening or the proliferation of the endometrium is caused by the estrogen. Okay, but that's not what the estrogen does only. It also induces the expression of the progesterone receptors. Okay, this is important because after the estrogen falls down, when the luteal phase starts, there will be progesterone, right? If there is no increased expression of the progesterone receptors before that starts, there won't be they won't correspond, or they won't respond to the progesterone increased levels. Okay, so that they even proliferate more, and then the secretory phase start. The secretory phase start, we said, with progesterone from the corpus luteum. Okay, quick revision. We said corpus luteum formed from cholesterol, which brings progesterone, which brings androgens like testosterone, and some estrogen. Okay, so progesterone from the corpus luteum, and this will shift the proliferative to the secretory phase. Something very important to know in this whole lecture is what starts and what ends, like what hormone starts and what hormone ends every phase. Okay, so for example, we said what hormone starts the proliferative phase? It's the estrogen. What hormone starts the secretory phase? It's the progesterone. Okay, this is important to know because they will test you about this in one way or another. Okay, so the shift from the proliferative to the secretory phase starts by the progesterone. Okay, it will inhibit the growth of the endometrium خلاص because it reached its peak, and it will start inducing a nutrient-rich secretion from the uterine glands. Why is that important? That's important in case there's pregnancy. So in case the egg gets embedded in the endometrium, we want it to have a nutrient-rich environment, okay, in order for it to grow perfectly. So the secretions support the viability of the implanting of the blastocyst, which is the egg, and yeah, the progesterone makes the surface epithelium more adhesive, creating a window of receptivity for the implantation. This is again all for the sake of the implantation or the pregnancy, in case it happens. Okay? The progesterone downregulates the estrogen receptor and induces conversion of estradiol to inactive estrogen. Alright, this is basically talking about estrogen. Okay. This is the endometrium in histology slides. I'm pretty sure you covered it in histology lectures. So focus on it there, but here it's just mentioned quickly. Any quick revision of it. So the first picture here is the proliferative phase, as you can see. So we can see that the functional layer is relatively thin, the stroma is more cellular, and the glands are straight, narrow, and empty. Okay, so here are the glands. They're straight, they're narrow, they're empty. Okay, and it's not like the stroma is more cellular. Okay, however, here in the secretory phase, okay, the functional layer is less heavily cellular and thicker. Why? It's because there's the tubular glands get wider, and their lumen starts filling with the secretory like product, and yeah, the lacuna are widespread and filled with blood. So here are the lacuna. This whole thing, all of those are lacunas. These are what we mentioned as what we said here are the venous lakes. Okay, so those venous lakes will be filled with blood. Okay, why is that? It's because خلاص, in case the progesterone falls, it will be shed, and menstruation will happen. Okay, the glands, the tubular glands, as we can see here, they're coiled. So this whole thing, like everything here, it's coiled. Hey, and yeah, they're thicker. So if you compare this picture to this picture, we can see that it's darker, it's thicker, everything. So I think كمان it's important to know how to differentiate between both of them by just pictures, okay? All right. So this is like just another like quick revision of the whole thing. I know by now you must be tired of how many times you repeated it, but to be honest, the more you repeat, the better, because you memorize it. خلاص it will stick. وإن شاء الله it will be easy on you. So what they're saying here is that um I think صراحة we said everything. Yeah, I'll just go over the clinical box here because and yeah, I'm pretty sure we covered everything before. There is this point here that we didn't cover. It's that the low progesterone levels induce COX-2. What is COX-2? It will bring, or it will increase prostaglandins. Those prostaglandins will cause the period cramps that or the pain that happens with the menstruation, and it's because of the contraction of the myometrium smooth muscle, okay, and the smooth muscle of spiral arteries. This vasoconstriction and vasodilation will cause necrosis, which the onset of the tissue repair is mediated by increased estrogen. Yeah, so this is like another point, you know. But here the clinical box, he's basically saying, like he's basically defining a couple of medical terms. First of all, there's menorrhagia. Menorrhagia is when the menstruation is heavy. So the bleeding is heavy. It's losing more than 80 milligrams of blood. Okay, that's menorrhagia. Dysmenorrhea is means painful periods. Okay, so period experiences can or like menstruation experiences can be different from person to another, but when they're painful medically, we call them dysmenorrhea. Um, few irregular periods are called oligomenorrhea, and the absence of a period is called amenorrhea. Okay, this may be due to dysfunction or stopping of the HPO axis, which is the axis that stimulates the gonadotropin releasing hormone from the hypothalamus to the pituitary and so on. That's what we call as um, the HPO, or the hypothalamus pituitary um, axis. Okay. For these terms, صراحة just know their meaning, because in case they mention it in the exam, you'd want to know what they mean. But yeah, inshallah they're easy. This is the diagram once more, but I'm not gonna go through it صراحة because خلاص we went through it a couple of times. I hope by this time, inshallah, you're confident with it. Inshallah, it's easy. Okay, here's another checkpoint if you have any questions. I hope it's good, inshallah. Okay, now that we're done with all the effects of the estrogen and progesterone on the reproductive tissues, the menstrual cycle, and all of that, we're going to discuss their effects on the non-reproductive tissues, okay? So there are so many organs and systems that the estrogen and progesterone affect. There's bones, liver, cardiovascular, skin, CNS, and adipose tissue, and so on down there. But okay, first of all, the bone. The estrogen effect here is that it fuses the epiphyseal plate of the long bones. Okay, this is first. Other than that, it favors bone formation over resorption. What does that mean? It allows the survival of the osteoblasts. I think you guys didn't take MSK yet, but what does that mean? Osteoblasts are the cells that form, or yeah, that form bone. Okay, they're the ones that make up bones. The osteoclasts are the cells that break down bone. Okay, So when it allows the survival of the osteoblasts and it kills or allows apoptosis of the osteoclasts, it favors bone formation over resorption, okay? Which is good because why? It's because when we all know, I told you what menopause is. Menopause is when periods or menstrual cycles and okay, and that is at a certain age, for a female, usually around 45, 50s, something like that, can be less or more depending on the female's health and so on. So when menopause hits, it's they those females most likely get osteoporosis. Why is that? It's because خلاص their estrogen levels drop and the bone formation is not favored anymore. What's favored is the bone resorption. Bone resorption will cause osteoporosis. Osteoporosis, what we know is as just lipoma. It's I think you'll take it more. I don't know why I have. There's no need for me to go over it, but I think you know it. Okay, that's it for the bone. The liver, the estrogen increases the expression of the LDL receptor. The LDL is the good, and I know you know this from oil, come on. It's the good cholesterol, okay? So increasing the expression of the LDL receptor is good. And it decreases the amount of the LDL circulating in the blood and increases. No, wait, I'm sorry, I messed it up. The HDL is the good cholesterol and the LDL is the bad cholesterol. So when we say that it increases the expression of the LDL receptor, it's good. It means that when the receptors are increased, they go from the blood and to the receptors in order to be like recycled or something, okay? So decreasing it from the blood is what we want, okay? This is good. And increasing the HDL levels is good, okay? I'm not gonna go into details of every single one because it's not as important. Dr. Abdul didn't go into details too, but just know these as points, okay? As like set points without details, okay? Next is cardiovascular. How does estrogen work here? It's basically, again, when we talk about like postmenopausal women, another like comorbidity that they have, another disease that they that comes up with menopause is cardiovascular diseases. Okay, so before menopause, they're usually lower. They're usually at lower risk of cardiovascular diseases, and then after menopause, they're at higher risk. Okay, it's because the estrogen promotes the vascular smooth muscle relaxation and vasodilation by the NO, which is the nitric oxide, and it inhibits platelet activation. Okay, inhibiting platelet activation is good because it won't cause clotting and atherosclerosis and so on. Okay. Next off is the skin. What happens here is that the estrogen induces the proliferation and inhibits the apoptosis of keratinocytes. This is important because keratin um, um, is important for like the skin. Not only that, it's the estrogen and the progesterone will increase the collagen synthesis and suppress its breakdown. Again, collagen is very important, and it does decrease as we age. So that's why the skin gets loses its elasticity and so on. CNS, which is the central nervous system, the progesterone resets the hypothalamic body temperature set point and slightly elevating luteal phase temperature. Okay, progesterone is a CNS depressant, so loss of the hormone after the uterolysis, which is the corpus luteum like lysis or breakdown, may be a cause of PMS or PMDD, which we will talk more about later on. But yeah, just keep this in mind, okay? Last point here is that the estrogen decreases adipose tissue by decreasing the lipoprotein lipase activity and increasing the hormone sensitive lipase. So lack of the estrogen will result in the accumulation of adipose tissue, which will maybe even cause obesity and so on, especially in the abdomen, which is the worst type of fat accumulation. All right. Okay. Now we have around two. No, I think like two or like four. If we count the PMS and PMDD, clinical correlations. Okay. And صراحة they are important because this is like a free mark if you know the syndrome and so on. First off is the Turner syndrome, okay? What happens here is that we usually know that a female has two, the female chromosome has two X's, okay? In Turner syndrome, they have only one X, okay? And this gives a 45XO karyotype. Just know this, okay? What does this affect? Causes gonadal dysgenesis, okay, or congenital hypogonadism. This will lead to like disruption of the hormones released, okay. When the hormones are affected, mainly the FSH and the LH, it will affect the ovulation and the ovaries. When there is no ovulation, there is no menstruation, there's no menstrual cycle, there's no pregnancy, so on. So all of that is linked to the menstrual cycle. The reason we're mentioning the syndrome here is because like because of the congenital hypogonadism, it inhibits all of the menstrual cycle and so on. The major clinical features of this syndrome is usually short stature. As you can see here, hold on. Okay, so short stature, webbed neck. So I don't know how to describe it صراحة, but it's like a wide webbed neck. Okay, low set ears, a shield shaped chest, which is usually just like a flat chest, as you can see here, and short fourth metacarpal, which is this finger. So usually you can see that the first, second, and third metacarpals are normal, and then the fourth and maybe the fifth one are short. Okay, this is how parents usually or like pediatricians usually know like diagnose the patient or the kid with this syndrome. Okay. Another thing كمان that Dr. AJR mentioned is that they have a higher risk of aortic bicuspid deformity. It's because like I don't think it's important. Just know that they have a high risk of aortic bicuspid deformity and aortic dissection aneurysm, and know that their internal and external genitalia are typically female, because I'm pretty sure in the exam you'll have more questions about like endocrine like syndromes and so on, that like the main giveaway will be whether or not their external genitalia shows as female or male and so on. So just so you don't get them messed up with the other ones, know that it's typically a female one here, even though it only has one X. Okay, this is it for Turner syndrome. And try to memorize those pictures because they might come up in the exam. So it's also like a free giveaway here. All right. Second syndrome is the PCOS. I think so many people heard about it already. It's very common nowadays, unfortunately. But polycystic ovarian syndrome, or PCOS, it's caused wait, let me bring that. Okay, it's mainly caused due to the increased amount of LH and the decreased amount of FSH. I don't know why my handwriting is bad, بس يلا. How does that happen? It's because of first of all, it's chronic, okay? Chronically and ovulatory woman syndrome. So they mean that the female having PCOS will chronically be unable to ovulate. Okay, why is that? It's because of the high LH levels, estrogen levels, and androgen levels. Okay, what basically happens is that the hypothalamus, as we said, it releases the gonadotropic releasing hormone, but in very exaggerated amounts, and increased pulse frequency and amplitude and so on. Okay, this will increase the amount of LH. Why not LH and FSH? It's because there's the frequency and the amplitude is so high. We said that when it's high, she releases LH, and when it's low, it releases FSH, right? So because it's so high, it only releases LH and decrease the release of FSH. When there's so much LH being released, it goes to the ovaries, stimulates the follicles. No, it goes to the ovaries and arrests the follicles. Okay, so they won't be able to grow or increase in size because there's no FSH. Okay, this will increase the circulating free androgens. Okay, androgens such as testosterone and so on. What does this have? What does this cause? We know testosterone is the male's hormone, right? So we can already guess what will happen. One of the symptoms that will happen here is this hirsutism and acne, which is increased in hair production in areas where a woman doesn't usually have that much hair. Okay, such as you can see here in this picture, the neck and the beard area and so on. Okay, this is usually how patients discover their PCOS. It's usually because of the hirsutism. With that comes the acne. Why? Because it's stimulating not only the hair follicle growth, but also the sebaceous glands around the hair follicle, which will increase the amounts of the gland's production, and might block the glands and cause acne. Okay, so this is one of the symptoms. Another could be increase in the adipose tissue. So they might start putting on weight. There will also be hyperinsulinemia. All right, so increased amounts of insulin in the blood. So it's mentioned here. So patients with PCOS may have increased BMI. BMI means like weight and so on because of the adipose tissue, as I said, with insulin resistance and hyperinsulinemia. It's all linked, okay? Insulin will promote the ovarian and androgen production. So, it's a cycle, okay? I mentioned this. The follicles will fail to ovulate because the gonadotropins causes ovarian enlargement and not enough FSH is released. All right. Okay, yeah. This here is just a point made by doctors to patients with PCOS. They usually recommend weight loss therapies, exercise, metformin, so on, in order to decrease or reduce the amounts of insulin, which might help improve PCOS. Okay. But why exactly do we call it polycystic ovarian syndrome? Polycystic comes from how do the cysts happen? It's usually because those eggs or the follicles that are arrested, or follicles that are arrested in the ovaries, can't grow, right, because of the low FSH. What happens is rather than growing, some fluid build up happens inside of the follicle, and it grows abnormally to become a cyst. And so not one follicle, that won't happen to just one follicle, to happen to multiple follicles. So there will be polycysts. So poly means multiple cysts in the ovaries. Okay, so polycystic ovarian syndrome. This is usually about it. I think I covered everything. And yeah, I'll try to also link this to like any pictures you see of hirsutism, acne, obesity, and so on. Okay. All right. Now, these are just main like some quick points that he mentioned. He talked about anovulatory cycles. Those are cycles which ovulation fails to happen, and so it's common. These are usually common in the first couple of periods and the last couple of periods, like the first ones after menarche and the last ones before menopause. Okay, and it does happen like not as often, but it does happen from time to time. In anovulation, there is no corpus luteum found, and the effect of the progesterone on the endometrium is absent. The estrogen continues to stimulate growth of the endometrium, making it thick enough to break down and slow off. So menses or menstruation, and bleeding in the ovulatory cycles vary. So some of them might have like a light period. Some of them might not have um like at all, and some of them might have a heavy one عادي. But generally it occurs in less than 28 days from the previous menstrual period, and the flow is also inconsistent and ranges from scant to very profuse. Okay, so these are like not as common. These are like rare cycles. Okay, another points that I mentioned here are those menstrual related headaches. Okay, those are common. Those are very common. Okay, I'm pretty sure most of the women around the world experiencing menstruation go through like those headaches, and those are very physiological headaches. Why? Yani it's not something they can control. It's usually triggered by these like peaks and like the increase and the decrease of the hormones will stimulate neurotransmitters. Okay, those neurotransmitters will vasodilate and vasoconstrict the vessels. Which vessels exactly? The intracerebral vessels, or the vessels found in the brain. When these vessels vasoconstrict and vasodilate, or maybe even just vasodilate, um, it will like cause nerve stimulations, which will result in headaches. You don't need to know the details. Just know that the menstrual related headaches are caused because of the estrogen decrease, the neurotransmitter serotonin decrease, and the increase in substance P, which will cause vasodilation in the intracerebral vessels, which will cause headaches. Okay. All right. Um, Here's PMS and PMDD that I told you guys that I mentioned before. So PMS and PMDD are also common, might be common and are getting even more common nowadays, unfortunately, due to like bad lifestyles and like health of women and so on. But basically PMS is premenstrual syndrome. It's symptoms that include mood, behavioral, and physical changes that occur before menstruation and fade after a period. If this if it includes like unhappiness, restlessness, dissatisfaction, and frustration, as you can see here down, like so. Oh, sorry. So it becomes more severe. We call it PMDD. Okay, so premenstrual dysphoric disorder. Um, Even though the hormone patterns are normal in those disorders, the yani, the reason I want to say no, the reason those patients get those syndrome or in disorder, it's not due to the irregular hormone patterns. No, their hormone patterns are so normal. It's just that those women have a greater sensitivity to the cyclical changes in the hormones. So it brings about all those symptoms. So it's the same hormones, same levels, everything. It's just the increased sensitivity to those hormones. Okay. Peaks and all those increases and decreases of the hormones bring about all those symptoms. We do have some hypotheses regarding this because we are not very sure about them. So first hypothesis can be that the symptoms are caused by the luteal phase progesterone, causing changes in the CNS GABA receptors. What this means is that basically it like صراحة it's not, I don't want to like go into details because I don't think كمان it's important. I'm just trying to like make sure I mention what Dr. Abdul Jabbar mentioned. I don't want to like overwhelm you with extra details or so on. Just know that the progesterone interacts with the GABA receptors and causes this syndrome. Okay. Another hypothesis, which is that the increased pre-ovulatory estrogen and the post-ovulatory progesterone, or both, trigger the symptoms. So remember how we said, like during the follicular phase or the first half of the menstrual cycle, there's more estrogen, and during the second half, there's more progesterone. This increase of the estrogen or the progesterone or both of them will trigger the symptoms of the PMS and PMDD. Okay. Now the last point here is okay. So basically, here's also another hypothesis is that doctors found out that there were some women who presented to the clinic with PMS, okay? But they were later on like diagnosed with depression for another cause maybe. So they were treating that depression with SSRIs, so selective serotonin reuptake inhibitors, okay? Serotonin is I'm pretty sure you guys know serotonin is the feel good hormone, okay? It's like the happy hormone. It's what induces happiness, okay? So that's what we give to people with depression. Those patients who were on SSRIs felt like better when it came to PMS. So it didn't only resolve their depression, it also resolved their PMS. This brought about another hypothesis that the serotonin is linked to the PMS, because we do know that there are mood changes in the PMS, so maybe that's why, that's the factor, okay? And yeah, yeah, that's it. Dysphoria again is a state of generalized unhappiness, restlessness, dissatisfaction, or frustration. So it's the severe, like it's severe PMS. It can be caused. I think he mentioned like postpartum patients. So patients after they pregnant women after they give birth, they lose their placenta. What is the placenta full of? It's full of progesterone. Remember how I told you if the ovary or if the egg gets implanted in the endometrium, it the progesterone keeps getting increased. Like it does not like decrease, and this constant like high level of progesterone throughout all the pregnancy, and then the drop of the progesterone as soon as the woman or the pregnant woman gives birth will cause postmenopausal depression. So this is another reason why we think the progesterone acts or like is linked to the PMS and the PMDD. Again, this is all hypotheses, but you need to know them because these are what they're gonna test you about. Okay. Yeah, that's it. I'm going to show you guys some questions I have here. Oh, oops, you didn't see that. So I did collect those questions. Some of them are I think like one or two of them are from previous exams. My exam from the 15th batch, and some of them are just practice questions. All right, so the first one here is that the birth control pills containing combinations of synthetic estrogen and progesterone compounds that are given for the first 21 days of the menstrual cycle are effective in preventing pregnancy. What is the explanation for their efficacy? So, why do they prevent pregnancy? What is it? I hope by this point, you guys all, like understood everything. Um, inshallah, you don't have any questions. Inshallah, it's all clear. But if you do, I'll be more than glad to like answer anything. So, do like text me, send me an email. I don't mind. Even if you don't understand any of those questions I'm showing you right now, um, do text me, of course. I'm just gonna go through them quickly because yeah, for the sake of the recording. Okay, so the answer here is A. It's well, like, why do they work so well? It's because they prevent the pre-ovulatory surge of the LH secretion from the pituitary gland. Okay, so that's why they don't release the um egg, or the ovulation does not happen. Okay. Here's an explanation too. You can read that. Next question is, as menstruation ends, estrogen levels in the blood rise rapidly. What is the source of the estrogen? I told you guys this is very important to know. The sources of um the source of estrogen, the like where does what stimulates LH, what stimulates FSH, why does this happen, what marks off the beginning of the phase, what marks off the end of the phase. All of those might seem as like small questions or like quick questions, but they do ask them. Okay, so the answer here is B. The developing follicles, as I said, as the follicles increase in size and grow bigger, they release estrogen. Okay, this is to for the negative feedback. It's to inhibit the um the body, or like it releases it to the pituitary gland so that it can stop releasing FSH. Okay. You can see here in the explanation, it says the corpus luteum also um, is a source of estrogen, because we said that it's built, any, I'm repeating this again, that it's composed of cholesterol, which turns into progesterone, which might turn into estrogen, right? But you have to focus in the question here. It says as the menstruation ends. So and when the menstruation ends, the developing follicles are what is secreting estrogen. When the menstruation begins, it's the corpus luteum that degeneration that is شو اسمه secreting the estrogen. Okay. Before the last question, I believe, a young woman is given daily injections of substance beginning on the 16th day of her normal menstrual cycle and continuing for 3 weeks. As long as the injections continue, she does not menstruate. Okay? The injected substance could be which of the following? What is stopping the young woman from menstruating? I highly recommend, if you like, you could stop the video. If you're watching the recording, you could stop the video and answer those on your own before like me answering the questions. So it's E, human chorionic gonadotropin hormone. I told you guys, um, whenever the embryo is implanted in the endometrium, it releases hormone chorionic gonadotropin hormone. This will tell the body that we have a baby, we have a fetus. Please keep the progesterone coming. Okay, we need it. And if the progesterone keeps increasing and coming, it won't allow the endometrium to shed off. It won't allow it to lose its thickness. It won't allow it to it won't go down, so there won't be any shedding of the endometrium. Thus, there won't be menstruation. Okay? Inshallah, it's good. Inshallah, all is good. Last question. During the 12-hour period preceding the ovulation, which of the following is true? So, ovulation, we said, is around halfway through the cycle, 14th day. In the 12-hour preceding the ovulation, what happens? What brings about the ovulation? B. A surge of LH, or luteinizing hormone, is secreted from the pituitary. This should be so easy, inshallah, yani. Because we mentioned this a couple of times, this is very important to know. What causes ovulation? LH surge. What causes LH surge? Increased estrogen, due to the developing follicles. What level of estrogen, increased estrogen, will cause this? We said over 200, right? Yeah, over 200 for like a day or so, 2 days, will stimulate LH, which will come as a surge of LH and secrete and yeah, bring about ovulation. I believe that is it. Thank you so much for whoever stuck all the way through. I hope, inshallah, it's beneficial, even at the slightest. Again, feel free to contact me for any questions whatsoever at any time. Here is a QR code that you can scan and share your honest feedback. I'd be so appreciative of any feedback you can share, whatever it is. Let me know if there's anything I can change, or what do you like, what do you not like about my paths. And yeah, that is it. Thank you so much. Inshallah, your exam goes great. And yeah, thank you.